panels will have 3 presentations followed by 25 minutes of moderated discussion. And that's going to include a mix of pre-prepared questions as well as some questions from the audience. So if you do have questions that come up as you listen to the presentations, please put those in the Q&A box. Our first panel is Advancing Success in Obesity Prevention, What Works Where and for Whom. It's going to be moderated by Dr. Shiriki Kumanyika, who is a research professor at Drexel University, Dornsife School of Public Health. And she was also a co-chair of the workshop and was really instrumental in driving the direction of this work. So Shiriki, really excited to have you moderating. I'm going to hand things over to you to introduce the panel.
Thanks, Dan. So I am really delighted to be a part of this in-court event. And I want to begin by just thanking the keynote speakers for setting us up for a wonderful discussion. I can't think of any better, start we could have. This panel is on advancing success in obesity prevention, what works where and for whom. We will have 3 presenters. I will briefly introduce them all, and then we will have the presentations in a row, after which we should have about 20-25 minutes for Q&A. So we will try to answer as many questions as possible, although I will probably start off with the privilege of the moderator and ask each presenter at least one question. So for the introductions, Dr. Stephen Gortmaker will go first, and he'll talk about his research applying cost-effectiveness modeling to evaluate various obesity prevention strategies. Dr. Gortmaker is a professor of the practice of health sociology and directs the Harvard Chan School of Public Health's Prevention Research Center on Nutrition and Physical Activity, as well as the Childhood Obesity Intervention Cost Effectiveness Study called Choices. His research has documented the energy gap responsible for recent increases in obesity among children and youth in the United States, and the important role played by excess intake of sugar-sweetened beverages. Next, we will have Dr. Russ Pate, who will share findings from the Healthy Communities studies, which he led, and that was a large observational study of childhood obesity prevention efforts across the United States. Dr. Pate is a professor of the Department of Exercise Science in the Arnold School of Public Health at the University of South Carolina. He's an exercise physiologist with interests in physical activity and fitness in children and the health implications of physical activity. Among his many accomplishments, Dr. Pate is well known for his leadership role with the U.S. National Physical Activity Plan. We have dietary guidelines, and thanks to Dr. Pate and his colleagues, we also have a National Physical Activity Plan. Our third presenter will be Dr. Christina Economos, who will talk about some of her work in applying systems approaches to community-based obesity prevention. Dr. Economos is the dean at the Friedman School of Nutrition Science and Policy at Tufts University, where she is also a professor and the New Balance Chair in Childhood Nutrition. Dr. Economos currently serves as the principal investigator on multiple large-scale community-based studies that examine childhood nutrition and physical activity with the goal of improving the health of all of America's children. So now I'll call on the presenters, and I'll begin by turning it over to Dr. Gortmaker.
Thanks, Shiriki, so much. And thanks for the opportunity to talk today. You can go to the next slide. These are my disclosures for different funders of this work. Next slide. The challenge, and all of you, I'm sure, probably know this, is that obesity and severe obesity rates in the United States continue to increase. Our studies indicate that about half the adult U.S. population will have obesity, and about a quarter will have severe obesity by the year 2030, unless we start to change things. You can see on the charts there, well, these increases are happening pretty steadily and quite predictably. Among children, obesity rates are at historically high levels, And our studies predict the majority will have obesity by age 35. And at the same time, racial, ethnic, geographic, gender, and income disparities are growing. Next slide. Now, these rising obesity rates and disparities are driven by many forces: the social and economic determinants of health, structural racism, the commercial determinants of health. All of these influence the neighborhoods where people live, household income and wealth, racial segregation, concentrated poverty, and the foods and beverages that people consume. You have to hit the next, I think, movement to get the next thing to appear. There you go. These are powerful forces. They're difficult to change. Next slide. To change these relationships, we need interventions. And we've worked to identify cost-effective preventive strategies. There's been a lot of focus recently on weight loss drugs. These are kind of expensive treatment strategies. Long-term evidence is lacking. What we've focused on here are population strategies that can prevent excess weight gain and obesity among children in the first place. And we found in our work that there are many program and policy strategies that are quite low cost, effective, and sustainable. We've reviewed about 130,000 studies in this search, and we've tried to find feasible and replicable strategies with good evidence that they can improve nutrition and physical activity, prevent excess weight gain, improve population health, and advance health equity. Next slide. So we have a microsimulation model that we used with this evidence that we've gathered to project how these different strategies can really alter the course of the obesity epidemic by identifying how a particular strategy will impact obesity in the future, healthcare costs, and quality-adjusted life year outcomes over a decade. As you probably know, there's strong evidence linking excess weight gain and the future risk of diabetes, heart disease, many cancers, mortality, higher healthcare costs, and quality-adjusted life years. Next slide. The key inputs we need for these models are just the potential reach of the intervention, the effect of the policy or program on the health outcomes, like the impact on excess weight gain. And this is typically done through evaluations, randomized trials, or natural experimental designs. And finally, the cost of the intervention, the implementation cost, and if there are any healthcare cost savings offsets. And again, we've focused on the cost effectiveness implementation of strategies. Next slide. I'll give you a couple of examples of policies that we've looked at and evaluated. But these have both actually already been implemented. I think they provide a good illustration, though, of what we might find or what we might hope to find. The first one is just a strategy to improve the food environments for children, the low-income children in particular. And the second one is really to improve nutrition in the marketplace. Next slide. The WIC program is operated by the U.S. Department of Agriculture. It's focused on safeguarding the health of low-income women, infants, and children up to age 5. It has about 6 million participants, 1/3 of all infants in the U.S. In 2009, a substantial intervention took place. The allowable food list was updated to support improved nutrition. WIC benefits can only be spent on certain foods. On the next slide. And a series of evaluation studies showed that the participants in WIC, after this intervention happened, purchased and consumed fewer calories, less juice, more whole grains, more fruits and vegetables. And a study we did of state-by-state variation over time, both before and after this was implemented, show that before the intervention, the percentage of 2- to 4-year-olds participating in WIC with obesity was increasing each year. And after this change was implemented, the percentage of 2 to 4-year-olds participating in WIC with obesity has been decreasing each year. We put these results into our microsimulation model, and we go to the next page. And we've projected that, or actually calculated, that this intervention, this policy change, prevented about 62,800 cases of childhood obesity. This was the last model year we looked at an implementation cost of about $1.77 per child per year, or per person per year. We calculate that this was quite a cost-effective intervention at a cost of about $10,600 per quality adjusted life years. There are no hard and set thresholds for cost per qualities. Some people say 50, 100,000, 150,000 per quality would be cost effective. This is clearly below that. And in terms of the health equity impact, all the cases of obesity prevented are among children from households with low income. And so really this is likely improved, very likely improved equity by income and race, ethnicity. And the details are in a pediatrics paper headed up by Erica Kenny that just appeared. Next slide. Second intervention that we've looked at and modeled is the sugary sweetened beverage excise tax. This is one at the state level. It's basically an excise tax assessed on manufacturers, bottlers, and our distributors of sugary drinks based on the size of the beverage. Sugary drinks account for nearly half of the total added sugars in a typical American diet. About half of adults, over 60% of kids consume a sugary drink on a given day. And evaluations of taxes implemented in multiple cities in the US, including Berkeley, Oakland, San Francisco, Philadelphia, and Seattle, have indicated effectiveness in reducing sugary beverage sales and consumption, which is not surprising. If you substantially increase the price of a good, people will buy less of it, just like with taxes on tobacco. Next slide. So in a recent study, this was headed up by Matt Lee, that just came out in the American Journal of Preventive Medicine, we projected that a sugary beverage tax statewide in California of 2 cents per ounce would prevent 266,000 cases of obesity in the final model year at about 9 cents per benefiting person per year. This would be a cost-saving intervention, meaning that it would save more in future healthcare costs than it costs to implement. And we also calculated that you'd have a greater reduction in obesity prevalence among Black or African American and Hispanic or Latino populations and populations with low household incomes. And therefore, it's likely to improve health equity by race, ethnicity, and income. The other thing is that both lower and higher income populations could be expected to spend less on sugary beverages after the tax is implemented. This is because of the high price elasticity of demand. And in addition, and this is not included in the cost effectiveness analysis, but this tax is also projected to raise $1.6 billion in state revenue annually that could be used for other public health programs. Next slide. So these are examples of a couple of cost-effective strategies to improve nutrition environments in the United States. Similar strategies could be applied elsewhere. Both strategies are projected to be cost-effective. One is expected to be cost savings, and both are expected or projected to improve health equity. Next slide. And these also illustrate two pathways to improve health equity. For example, in the case of income-related disparities, if the strategy is focused on the low-income population, like the WIC program, and you improve the nutritional quality of the foods, you're likely to have these positive health equity effects. In the case of the sugary beverage excise tax, like we saw larger effects of the intervention among lower-income populations. And this is due to the fact that the lower income populations were consuming more sugary beverages at the start. And in addition, they had a higher BMI at the baseline, like where you get larger impact of the intervention. One limitation of these cost effectiveness studies, it's not really a limitation, but it's just the reality check is, while we have evidence for cost effectiveness and the impact of health equity of these interventions, collectively, these are not projected to reduce obesity prevalence in the US, but they will slow the increase. As we saw, things are going up pretty rapidly, and these interventions would slow the increase, but we need a wide range of strategies in many different settings, and I think that's where a systems perspective can be really helpful. The next slide. Finally, we've worked with partners in many parts of the United States to identify best value for money strategies that could work with particular states and cities. Next slide. We've worked with key partners, ASTHO, NACHO, the big cities, health coalitions in this work, as well as community partners and public health organizations in those cities and states. Next slide. Here's a map of some of the states and cities that we've worked with. And if you go to the next slide, you'll see examples of strategies developed and modeled with these partners. And I will mention a couple of these that are cost-effective strategies that also improve health equity. For example, water access at school lunch lines. We've studied that with the State Department of Public Health in California and Massachusetts. Movement breaks in the classroom, we've studied that with Massachusetts, also with the city of Boston. There's lots of different interventions here in the early care and education setting, as well as with sugary beverage taxes in a lot of settings. So there are a bunch of different interventions that we think can really make a difference, that can be implemented, improve health equity, and be cost effective at the same time. Next slide. I urge you to go visit our Choices Project website. You can scan this QR code. You can go visit. We have a national action kit that gives lots of detail about 20 different interventions, including the likely health equity impact, the cost effectiveness of those strategies, where the costs are allocated, and how these could be implemented locally. So thank you, and I look forward to having a conversation.
Thanks, Steve. I'll now invite Dr. Pate to give us his presentation about the Healthy Communities Study.
Well, thank you, Shiriki. I'm very pleased and honored to be invited to speak today about the Healthy Community Study. Purpose of which is stated here was to examine how community policies and programs are related to children's weight status. Next slide, please. Major partners involved in the study were the National Heart, Lung, and Blood Institute, which funded and oversaw, managed the study. The primary contractor was the Patel Memorial Institute, which was responsible for conducting the study, and 3 university partners served as subcontractors to Patel, UC Berkeley, University of Kansas, and the University of South Carolina. Next slide. Study setting was 130 U.S. communities. Community in the study was defined as the area served by a public high school closest to the center of a selected census tract, and the study constructed a stratified national probability-based sample. I think it was around 25 or so of the communities were included because they were known to have been very active in efforts to address childhood obesity. Over 5,000 elementary and middle school students were included in the study and recruited through their schools. Next slide. Community policies and programs, CPPs, implemented over the previous decade were assessed. They were efforts related to nutrition, physical activity, weight control, and prevention of childhood obesity. Information regarding the community policies and programs in each of the 130 communities was collected through standardized interviews with key informants and additional document reviews. Next slide. Community policies and programs were coded for multiple attributes, including the target behavior, behavior change strategy, duration, and reach. Over 9,000 CPPs were reported and cataloged. They were reported by over 1,400 key informants across the 130 communities. And in so-called intensity score was calculated and assigned to each CPP, and the intensity scores for all the CPPs in a given community were summarized at the community level. The intensity score was based on I would call it, I guess, traditional health promotion theory. An algorithm was created to create that score based on accepted health promotion theory. Next slide. At the children and parent level, measures were administered during a home visit. They included anthropometry, including height, weight, and calculation of BMI, self or parent-reported diet and physical activity behavior, depending on the age of the child, demographic characteristics, surveys of potentially related behavioral and environmental constructs, and for a subsample, height and weight was abstracted from the children's medical records back as far as 10 years. Next slide. Key analysis variables. I'll be today summarizing the findings for the BMI outcome, but in addition, analyses were completed for dietary behavior indices and a physical activity index, estimating moderate to vigorous physical activity. Independent variables included the number of CPP target behaviors in some analyses, and in others, the CPP intensity scores, which is the theory-based index. In some analyses, all of those were included as independent variables. In some cases, only those targeting diet outcomes. In other cases, only those targeting physical activity outcomes. Next slide. I'll now summarize the findings for the BMI outcome. In one analysis, total number of CPP diet and physical activity target behaviors and the number of physical activity target behaviors independently were negatively associated with BMI. This was a cross-sectional analysis, and I should probably digress for a second to say I do think of a healthy community study as fundamentally a cross-sectional study, even though there is a retrospective longitudinal element to the design. I do think of it as primarily a cross-sectional design. In addition, CPP intensity score was negatively associated with BMI trajectories estimated from the height and weight data from children's medical records. Next slide. The associations that we observed were not consistently significant across income, race, ethnicity, and geographic groups. The effects were less likely to be significant in kids from low-income families, in African American and Hispanic youth, and in communities with high proportions of African American and Hispanic families. Next slide. So to interpret these findings for the BMI outcome, one is that there was appeared to be sort of a mass action effect. More is better. Children living in communities with a greater number of CPPs tended to have lower BMIs. A second is higher intensity, higher overall intensity scores in the community were better. Children living in communities with greater intensity of CPP activity showed lower BMI trajectories. And then associations between CPP activity and BMI are inconsistent across demographic groups. In general, not significant in less advantaged groups. Next slide. I'm going to quote Shiriki here, and I should probably, in the interest of full disclosure, indicate that she chaired the OSMB committee that oversaw the protocol for the Healthy Community Study, and in a summary of our findings published as a special issue of Pediatric Obesity, she wrote, "The Healthy Community Study may be the first nationwide study to provide convincing evidence that the mainstream programs and policies being put in place to address child obesity in the United States are relatively less likely to benefit higher risk population groups." And I think, kind of an operative phrase there is mainstream programs and policies, those that, we observed in high frequency across 130 communities. Next slide. I am pleased to be able to tell you that that the work on the very extensive data set that was created through the Parent Healthy Community Study is continuing. There are two currently active studies that are taking advantage of the HCS data. One is entitled "Understanding Community Obesity Issues and Informing Tailored Community Interventions to Reduce Childhood Obesity." The three subcontracting universities that were involved in the parent study have continued to work together, and in this study are applying so-called CART analysis, classification and regression tree analysis, to the HCS data. I think this may take us a little closer to a systems approach to taking advantage of the HCS data. Next slide. And the second study is being led by Natalie Colabianchi at the University of Michigan. The title is "The Role of the Contextual Food Environment and Community Programs and Policies on Diet and Dietary Disparities in the National Healthy Community Study." In this study, data are being imported into the master analysis data set from other sources that were not available when the parent study was undertaken. And so this is adding considerably to the community level information that's available to look at associations in the HCS data. Next slide. So thank you very much for giving me the opportunity to kind of overview the findings of a very large study. And I'll look forward to our discussion here in just a few minutes. Thank you very much.
Thanks, Russ. I will invite Chris Economos to talk about her catalyzing communities approach, and then we'll be able to start the discussion.
Great. Well, thank you so much, and I appreciate the invitation to present today, and looking forward to a robust discussion. So this presentation will discuss how we can work with communities around the country to promote healthy child weights and while centering health equity in our efforts. We all know that children need healthier environments, and while healthier environments can look different, We desperately need innovative, research-driven approaches that really empower communities, people on the ground who take the evidence-based intervention strategies that most of us spend our careers developing and researching, and really equipping them with the tools and the evidence and the insights that they need to make lasting change. And that is really the focus of this work. Next slide, please. So this is really my own construction of how I have experienced the evolution of obesity prevention through the last 35 years that I've been working in the field. When I first started, I devoured individual behavior change theories and interventions that helped us really understand what the behaviors were that we needed to begin to target to show biological change. But we quickly saw that just one individual behavior would not be what we needed to actually change biology or risk for obesity and chronic disease, and started to appreciate the fact that our behaviors are influenced by policy and environment. And we started to develop a lot more policy and environmental interventions, and importantly, the tools to assess policies and environments. And a large body of research was conducted, in part funded by the Robert Wood Johnson Foundation through healthy eating research and active living research, so that we could go out into communities and really understand what environments and policies look like. And that led to the combination of individual behavior change nested within environments and policies, inspiring many of us to conduct what we call multi-level, multi-sector designs. And some of those were even implemented at the entire community level, where, as many of us have said already today, it's not one thing, but it's multiple things that need to be put forward in a portfolio to really see a change. And a number of whole of community approaches were done, many successful, which really led to the complexity and understanding that it was going to be very hard to actually move the needle unless we were doing a lot of things at the same time. And yet we didn't have the proper tools and way to really understand what was happening in these complex interventions. And that's when people really started to think more about system science and designing complex and responsive strategies so that we could use more sophisticated tools to both design, implement, and also evaluate what was going on. And that's really where my research has centered over the past 10 years. And recently, we've started to appreciate not just the social determinants of health, but structural determinants, and that interventions really need to appreciate the structural barriers to practicing a healthy lifestyle. And that has really led us to understand more about equity, because as many of us have been talking about, some of the structural interventions are longstanding things that have been in communities. Some of them are failed policies. Some of them were decisions made, decades and centuries ago that set some people up for the inability to lead a healthy lifestyle. Next slide, please. So one of the studies I conducted, it's now almost 20 years ago, funded by the CDC, was called Shape Up Somerville. And this was a whole of community intervention with multi-level, multi-sector approaches. And there were lots of good findings because we did put forward a pretty comprehensive suite of evidence-based strategies that at the time were shown to be effective. And so this resulted in decreased BMI Z-score, a reduction in prevalence of obesity for children and their families, some behavioral change, and some policy changes at the local level. And it was important at the time to give hope to the fact that if you do a lot of things at once, you can have an impact on biology. But in all honesty, it was very complex. There were a lot of people involved, and we didn't have the analytic tools to actually tell us what was the most successful for whom in what circumstances. So when the study was over, next slide, please, we started to map the dynamics of community change. And in this case, you can actually see a number of subsystems in the community, which are typical in most communities in the US, a food environment, the school system, community environment with community-based organizations, the built environment, media, families, and then, of course, the individual. And in the case of this study, in order to coordinate all of the efforts that we had underway, we formed a task force. And this task force was a group of individuals from the community that were responsible for leading the microsystems that you see here. We brought them together and we engaged them in helping to disseminate or diffuse the evidence-based strategies into all of the environments within the community in order to see what was the primary outcome, change in BMIC score in the children. If you could click, you can see that the Shape Up Somerville Task Force, located at the bottom, which was a group of dynamic individuals who did have power within the community, were really the heart and soul of this intervention. And we believed that without this task force, we would not have been able to influence all of these microsystems and to put forward a portfolio or a suite of evidence-based interventions that were actually taken up by many, many different organizations and microsystems in the community. Next slide, please. So we really started to explore the role of a coalition. And we realized that we didn't have a lot of measurements on these individuals. They were people who were coming to the table for 3 years, who were participating in the implementation of the intervention, but we had no sense of how they were changing as individuals or how their actions were really resulting in the uptake of the evidence-based strategies. So we realized there was a lot of work to do to look at the role of the coalition, not just in this study, but in coalitions that were operating across the country. And we really started to hypothesize that community coalitions, which are often defined as multi-sector partnerships who work together with shared goals, really leverage their collective knowledge and engagement to create what we know are social networks that really facilitate the implementation and sustainability of evidence-based interventions, all toward improving child health and preventing obesity. But really, we were lacking any kind of methodology or mechanism to really study this in more detail. Next slide. So the first thing we did was we really looked at other studies that had attempted whole of community interventions to try to understand what they had done and what they had seen. So this was a mixed methods review. And in this figure, you're seeing previously implemented childhood obesity interventions. And on the x-axis, it's the number of community engaged research phases that the investigators conducting the study had the community participating in. And you can see a number of studies on the y-axis and the results shown as either positive, mixed, null, or negative. And what this is really showing you here is there's a relationship between the number of phases where a coalition or a community group is engaged and the outcome of study. It is not a causal analysis, but it's really important for us to understand the vital role that such a group plays in the implementation of a successful intervention. So that really led, next slide please, to an NIH-funded study that I was co-PI on with Ross Hammond, who you heard from earlier, called Compact. And this is where we really started to implement system science methodologies to understand what was going on at the community level, retrospectively and in real time with whole of community interventions. And it was called Childhood Obesity Modeling for Prevention and Community Transformation. If you could click, please. We set out to understand and leverage existing systems within a community to implement an upstream approach to obesity prevention. And when I say upstream, I mean using a coalition or a group of individuals who are working for the entire community. And downstream would be an individual where we measure behavior and biology. Midstream would be policy, practices, environments, much of what Russ and Steve just talked about as the strategies that we implement in order to see downstream change. So our working hypothesis for this study was that stakeholder groups may be a driving factor in the success of interventions through a process that we now call stakeholder-driven community diffusion. Next slide, please. So the first thing we needed to do was develop more tools to actually measure these stakeholders, because as I mentioned, there were very few studies that were actually measuring what coalitions or what stakeholders were doing. So in this case, we really wanted to understand how are these stakeholders driving factors in communities. and we hypothesized that their knowledge and engagement are a large part of it. So we developed a tool that enabled us to measure the knowledge and the engagement of the stakeholders within communities who are given evidence-based strategies to implement. And as you can see here, there are multiple things that we look at within knowledge, like their understanding of intervention factors, roles, sustainability, the problem itself, and the resources that are available and that they have access to, as well as their engagement. You could think of this a bit as agency, their ability to engage in dialogue and mutual learning, flexibility, their influence and power, their leadership and stewardship skills, and their trust that they have with the people they're working with in the actual coalition and across the community. So we have a tool that we've iterated over time and published a couple different times as we've validated and refined it, that we use to actually measure the coalition activity. Next slide, please. And this is really important for our stakeholder-driven community diffusion theory and evaluation. So as I mentioned, you can see with a click on upstream, we convene a group of individuals called the coalition, and we measure their knowledge, engagement, as well as their social networks, their transformative learning, what they go through while they're with us, and the efficacy of the coalition. And we work with them over time to build their relationships and to change their systems insights. We review the evidence with them, which you've heard a lot about this today, including a lot of the work that Steve has done through choices to make sure that it is the best evidence not only available that will be cost effective or actually helpful in terms of the money they have to spend and getting the most out of it. And then we help them prioritize that. And last step is really taking action within the community. If you could click again, please. What we measure midstream is really social networks. And we look at first and second degree alters to see if these individual stakeholders are diffusing out into the larger community. Next click, please. And then finally, we measure, I think what we're all interested in is evidence-based changes in policies, practices, and environments. We also look at organizational readiness for communities that are, organizations within a community that are actually implementing this. And based on the entire body of literature that we all know, if this works well, you're likely to see child health outcomes. Next slide, please. So you saw a little bit of this earlier, but just to give you a sense of stakeholder convening, if you could just click twice, please. You can see that we engage these different community groups who have a whole group of individuals within that community group, anywhere from 4 to dozens. And we systematically select a group of individuals to be part of the coalition. And you can see on the bottom, they would come together to actually form this coalition. So people in a coalition may be representing hundreds of people that are part of organizations from which they come. Next slide, please. And we involve the group in community-based system dynamics, which we use group model building. And there's really a tradition of building models with groups of stakeholders. And you saw this earlier today from a couple of different speakers. So we help our stakeholders build models together and really externalize their mental models or the way that they interpret the world to make them more explicit and adaptable. And they work together to actually formulate what's happening in their community. And these models really combine the perspectives to create a holistic understanding of the complex problems that they are facing within their specific community or context. And this can yield informal maps and formal modeling. So next slide, please. This is an example of one of our the colleagues' work in Australia, where they've used a causal loop diagram, which you can see on the bottom, and overlaid a social network. So this really helps to use 2 different system science methods to understand the complex interactions between steering committee members or coalitions and the community context that influences success in obesity prevention interventions. So using these 2 methods together, they're able to really untangle a complex process and understand who's working where and how they are participating in these feedback loops that are happening within a community. Next slide, please. These data are the evolution of a coalition network, part of one of our studies called Shape Up Under 5. And I'm really showing you this just to show that we do this work over time. So here you can see 5 waves where we collected data from first and second degree alters within a community. And you can see that people come in and out of a network over time. And we're looking at things like influence, frequency, and discussion. So these are parts of social network analysis where you can really begin to understand how people are influencing each other, how frequently they are communicating, and what a discussion network looks like over time, how it becomes more dense, how people move into the center, sometimes out to the perimeter. And you can really begin to understand how specific people within a network or egos are helping to diffuse the strategies throughout the community. Next slide, please. These next visuals that I'm showing you are just different ways we use our social network data to understand connections and diffusion. So if you could click on the first one, this is a very large network from one of our communities where it's actually displayed by sector. So if you can see, it's color-coded by the different organizations and sectors within the community from which the first and second degree alters are from. And you can see how they're communicating, clustering, influencing each other. And this is really important to understand because oftentimes organizations are siloed or they don't work together. And so you can perform things like social networks to encourage or facilitate better discussion and collaboration. You can see who the most important individuals are in the network, who can be bridgers or amplifiers within a network. And this is all in service, again, of effective implementation of evidence-based strategies. If you could click again, these are data from Shape Up Under 5, which is a published study where we looked from baseline to follow-up. And we looked at 2 things here: the improvement in knowledge and engagement in the individuals in our social network over time. And you can see as the boxes and circles become darker or richer in color, their knowledge and engagement actually became stronger over time, which is what we want. And then you can also see that the network became better over time, and people were diffusing that knowledge and engagement across that social network. So this is exactly what we were looking to see in one of our first studies to demonstrate that our theory was working. One more click, please. And this is also showing a different way of looking at a social network from a first wave to a final wave in one of our studies, where we see coalition members who increase their knowledge and engagement in prevention efforts, their scores, they are most likely to become more central in the network and become more important influencers in information exchange. So there are lots of things we can do with these social network data in relation to the knowledge and engagement change, as well as how they're working together to implement interventions. Next slide, please. We also, of course, look at the midstream impact, which is policies, systems, and environments, because that's what we want to see changing in order to influence the downstream biology and behavior. So these are data from one of our studies where we looked at PSE change over time. This is community members reporting this to us, but you can see over 24 months in this study that the score was higher and it was significant. Next slide, please. So we've put all this work together to design a study called Catalyzing Communities, where we work across the country using this methodology with stakeholder-driven community diffusion to really empower coalitions to implement evidence-based strategies. Next slide, please. So we leverage approaches from obesity science and systems thinking to bring together multi-sector leaders. We surface their diverse perspectives, we build consensus and drive coordinated, comprehensive action. We continuously refine the approach through ongoing rapid cycle, rigorous evaluation of their transformation process, and we respond to the local needs of the community and the community readiness. Next slide, please. These are some of the communities that we're working with across the country. We have 8 communities right now who've been working with us, implementing evidence-based strategies that are context-specific with health equity at the center. And in the next slide, I'm showing you one of the causal loop diagrams from Greenville County in South Carolina. We published this as a case study. They were very interested in working in nutrition security and in racism, and they went on to use the methodology that we taught them to work with an equity group specifically to address structural racism within their community. The next slide is showing a causal loop diagram from Cuyahoga County, which is where Cleveland, Ohio is. And you can see another causal loop diagram. You've seen many of these with these microsystems within, but if you could click for me, what I'm really pulling out here are structural determinants. So if you look at these variables closely, you see that they're underlying structures that are really preventing communities from gaining traction and making the progress that we want. Things like toxic stress or trauma, poverty, poor or disconnected transportation systems, lack of political will, I would say, inequitable resource allocation. How does money actually flow across a community? So this enables us to really surface some deep leverage points that you heard about before to understand what's happening in a community. Next slide, please. What we've been able to do now is really pool our data from across communities, and we have a lot of papers in review. We're excited to share all of these findings with all of you, but this shows you their baseline engagement and knowledge scores from 8 different communities across different domains. And what I want to show you here is within the category of engagement, influence and power is systematically lower. So these are often individuals who are in positions where they want to make change, but they're really lacking the influence and power, which tells us the kinds of training that we need to do should focus on these variables. In the case of knowledge, their lack of resources, whether they have them or whether they have access to them, are often low, as well as understanding the intervention factors that are the most effective to implement. And that's where I think we all come in trying to disseminate that. In the next slide, I'm showing you common dynamics that have been described by 3 or more communities where we have developed these causal loop diagrams. So we've done it in 8, and at least 3 have cited different types of structural barriers like intergenerational wealth, poverty, struggle to meet basic needs, time trade-offs, and so on. And these are important to surface because we can't expect coalitions or community members to take up any kind of interventions that won't be possible if you're not addressing some of these structural barriers. And the next click will show you the top 5 codes within the causal loop diagrams. They're not necessarily dietary intake and physical activity. What people are concerned about are socioeconomic status, neighborhood and physical environment, the social context, the health states, and the food environment. Next slide, please. So some of the key takeaways from this work are that we're at an important inflection point in the field of obesity interventions, and we have to continue to really evolve our understanding of what underlies obesity risk and how to address it. I think today many of us are saying that system science is a critical piece of that evolution and can be used to design, implement, evaluate, and sustain effective prevention interventions. We have to center equity in all the work that we do to ensure we're reaching those in greatest need. And one of the other findings that's surfacing for us is a real shift in systems insights in our coalition members and a better understanding of health equity and structural determinants. And innovative efforts are definitely underway across the country. We're hearing about many of them today, merging rigorous science and community wisdom to address structural drivers that shape health outcomes. Next slide, please. I thank you all very much and excited now to engage in a discussion.
So thanks to you all. I guess all the panelists can put their cameras on. This has really been a wealth of information with potential lessons going forward. We pose the question in the subtitle of this panel is what works where and for whom. And we've had a lot of information about things that work in various places, and I want to kind of parse out this idea of how you pinpoint the equity focus. And I'll start with you, Steve. So you had a whole list of things that work, but we know from Russ's presentation, among other things, that sometimes disparities will widen if an intervention works for only one group. And I want you to comment on whether in trying to model these things, you found that it's only the targeted interventions that really will have the right effect on equity.
Yeah, thanks for that question, Shiriki. I guess certainly it's true that some of the interventions we've looked at, because they're targeted, do have a substantial impact on health equity. And I think the WIC package chain is a great example. We found basically the same kind of evidence for effect in every state in the United States. So that's an intervention that operates that way. On the case of the sugary beverage taxes, we've seen the impact on health equity there is different. And it comes about because the population is at higher risk. For example, the low-income population tends to consume more sugary beverages, has a higher BMI, and therefore, well, you get a greater impact of the intervention. But other interventions that we've looked at are kind of simpler, like providing water on school lunch lines. It's a pretty simple intervention that will work everywhere. We've seen it work in a couple of different places. And I think I'd also mention that by not implementing cost-effective and health equity producing interventions, that's a policy in itself that will drive continuing disparities and new disparities. But in all the different cost-effective preventive interventions that we've studied, we didn't really see any evidence for increasing disparities, perhaps because we've been looking at strategies that are often implemented in at-risk populations or throughout the entire population. Certainly some of the treatment interventions that people have been talking a lot about lately, like the expense of obesity drugs, I could certainly see those sort of treatment strategies, because they're quite expensive, as producing inequities, more inequities because of lack of access.
Yeah.
Hope that was useful.
Yeah, no, that's useful, and I can related to the question I want to ask Russ, because you mentioned the water provision, it works, but then I think about schools. I'm in Philadelphia, where there may be problems with the water, with providing water. And in those cases, if you didn't think that through in implementing the intervention, or you didn't have information on that, you could have an effect in some schools and then a negative effect in others, where people don't let the kids drink the water. So Russ, I wanted to ask you, in hindsight, even though you measured everything that you could possibly find time and resources to measure, can you think of anything that you would have wanted to measure, or that you would measure if you were doing the study again, insights maybe from your card analyses or something?
Well, we did measure a lot for sure. And to be honest, the work is continued, that really is aimed at trying to take full advantage of all the information that we do have. As you know, a lot of information was collected on schools in healthy community study, but not fully analyzed at all while the parent study was active. I think a uniqueness to the healthy community study was, number one, its scope. We were, in 130 communities. But we also had the resources to get on the ground and get into the kids' homes and collect data there with them and their parents, and to interact directly with the key informants in the community. So I don't know of another study that has operated both at that scope and has been able to collect data, of the depth and detail that that we did. I think our finding, and this is based on coming at the data from a number of different angles, continues to show that the socio-demographic characteristics of the communities are primary determinants of BMI. The analysis that we're currently working on are aimed at kind of taking a different approach to making use of the data. The parent study was really a hypothesis testing approach where the hypothesis was that the higher the CPP intensity scores, the lower the BMI. But that certainly didn't preclude the possibility that differently calculated intensity scores might have shown different associations with BMI. So the approach we're currently taking is the other way around, and it's take all the raw data and basically use it in large scale cart analyses that I think we're learning sometimes produce associations that are hard to understand or may seem counterintuitive, but sometimes they do make a lot of sense. So we'll see where it all ends up. But to be honest with you, I think we're still working to try to take full use of the data that we do have.
Yeah, I'm trying to figure out why you saw what you saw, but I think the fact that there was the oversampling of the high-risk populations was critical, because at least you could see that it wasn't working the same way in all those different populations. Yeah. So Chris, I mean, one of the takeaways from this whole panel, and especially from yours, is that the amount of things you might need to learn to make something work is like, overwhelming. And somewhere in there, you're trying to make an equity focus. And how do you do that? I mean, is it the communities you pick? Is it the way you train the community leaders? Where do you work that in? Nope, you're on mute.
Saw that. Thank you. I think it's all of it. And maybe I can focus more on the process than on which outcomes, just to add something different. And it is in, who you work with within a community, which communities you work with, how you build that relationship, what kind of equity commitments you make together, what kind of training you bring in to really understand what equity is in this particular context. And I want to give I want to put a lot of importance on the process part of it, because I think it's critical. If you're working longitudinally with a group of individuals, you have to really understand what you're doing, or you could end up choosing something that, as you've said, could widen the gap. And one thing that we did, and you're asking me the question, but I'm going to actually highlight your Getting to Equity framework and the checklist that was developed, that was really used more to score, I think, applications. But we took that and we used the checklist by overlaying it to the stakeholder-driven community diffusion framework. And every single step in that, we asked an equity question and we challenged ourselves. Are we really doing this by centering equity? And we realized there were many places that we could make changes. So that whole process, it isn't just saying, oh, we have equity in mind. It's breaking it down into the smallest steps that you're taking, from what literature you're looking at, who are you bringing to the table, how are you speaking to each other? I think that's why I want to emphasize process. And then importantly, are these outcomes having the impact that we want? But it's how the outcomes often get implemented, because they may be reaching some and not others. And that is really working with a specific group of people to make sure they reach everyone. So that's an emphasis I really wanted to make around the process part.
Yeah, no, that's very interesting and really helpful. I don't want to use up any more time with things that I'd like to talk to you about. So I see one question that's being fed by one of the team members. This is a question for you, Chris. is there any movement in the academic research space to create research findings and resources for community consumption? We struggle with bridging the evidence findings and working directly with communities to share information to support community decision-making.
Yeah, I mean, I would say that the biggest signal recently from NIH was the Compass money, which required communities and academic institutions to work together, and that is underway right now. I'm really excited about it. So that to me is a real signal from, you know, our funder that helps a lot of this work to happen. I think there's, the more we can use rigorous methodologies and data collection, and you know, I'm working with Ross on agent-based modeling, which is another piece of this. The more I hope we can all appreciate how important this work is, to be academically rigorous and practical and actionable at the community level. And I think that's what it's going to take to really turn the tide.
Thank you. Yeah, mentioning the compass, it's a good idea. So it's like, you know, NIH is catching up with the types of things that are needed that would have been unheard of, you know, a decade ago, I think, at least in this field. I see some questions. I just need to do a check. I see questions in the Q&A that I can, a lot of them are for Steve. So I guess I can, I think I'm just going to read some of the questions, and maybe you could give a more general answer, Steve, to these questions about that. And then I see one that's for, it says for any of the panelists can answer, but I'll start with this one. So Steve, you were getting questions about whether, for example, benefits spent on healthier foods also mean that that money is not available for buying unhealthy foods. You know, kind of the trade-off, and whether some of that can be taken into account in the modeling. There are also negative trade-offs, like, you know, people who don't have the time may not be able to cook the whole foods and stuff like that. And so in your modeling, are you looking at, you know, possibly unintended consequences or spin-offs? That's one.
Answer that one.
Okay.
Yeah, because I might then forget it. Yeah, I think it's a good question, and it's one thing that's happened. I didn't mention our evaluation of the Healthy Hunger Free Kids Act, just providing healthier meals in schools, but it's a relatively low-cost strategy that has prevented literally hundreds of thousands of cases of obesity, generally among low-income children, because that's where it's generally low-income children who use school meals the most. And it's been a real success, and it's pretty cost effective. I think it's what, $25 per child per year. And by providing school meals that are healthy, it saves low-income parents money. So they have more money to spend at home. And by spending on healthier foods, it of course just provides a role model for kids. There's a lot of positive benefits. We do try and take into account, though, all of the cost offsets or competing issues in where those dollars are spent. And so I don't know if that exactly answered their question, but it is an example of a program that's really useful. I mean, I think one of the findings for me, or overall issues, is that if you have any programs that provide foods for low-income populations, let's make them healthy foods, like what we do in the WIC program or the school food service. Don't make it so that you can get a bunch of junk food or ultra-processed foods through federal food programs. And I know that's complicated, and people may disagree with that, but that's been an effective approach in WIC and the school lunch program. Very cost effective and health equity producing.
Yeah. Thank you. I'm looking at the question that the attendee said anyone could answer, and it really is about the sort of 4-decade struggle of public health, trying to do various things. And if there's any advice to public health professionals to tackle the food industry to sell unhealthy foods in low-income neighborhoods and any communities to reduce diabetes, heart disease, and cancer. So the point I get from this question is, of the things you're doing or the things you're observing in the case of, the Healthy Communities study, do you see pushback on things like, marketing and what's available, or is it just being measured? I would say, I know it's being measured a lot, but is there any effort that you know about that's effective in combating that?
Well, that was for Russ, right?
I don't think so.
Yeah,
I think
I mean,
it's a great question. Like you say, the First Amendment issues often make it really difficult to limit marketing to children. And yet, if we could get our legislatures more involved in it, that might help, but it's been very difficult to make those changes. Chris, go ahead. Sorry, I cut in.
yeah, no, I mean, I totally agree with you. And I think lots of people have spent a lot of time on it and clearly demonstrated that the marketing is uneven, right? And we know that it's prevalent to market unhealthy foods in certain areas, and yet it persists. And, I guess I'll just turn it and say what I have seen is at the community level, people who are really dedicated trying to both shift the distribution of funding. So there's more funding toward healthier food, whether it's local or imported or food entrepreneurs of color who are trying to make a difference. So that movement, I think it's not going to displace the other work going on, but it is a movement right now. And people want to reclaim their communities, their health, their dignity. And I'm seeing a lot more of that. So can it get big enough to push out some of the unhealthy foods? And you're getting to equity framework, that's a quadrant. We have to do both. I'm not sure, but I think we need to do our best to continue to empower, support, collect data, and produce evidence that some of that work is working.
Yeah.
I think I'll add one thing there, Shiriki, that even though it's not that big, the labeling efforts, restaurant calorie menu labeling around calories, and then the supermarket calorie labeling around prepared foods in supermarkets, we found that both of those are cost-saving strategies that have positively impacted all different parts of the population. It hasn't necessarily improved health equity, but it's improved population health at very low cost. The cost-saving strategies, and so that can be expanded.
Yeah, I think that's good. And then, as Ross Hammond pointed out, if you pair that with some other things, with the education and other things that are sort of natural, partners with that, then it may even have more of an effect, because people know why they're looking for something on a label, for example. Okay, well, I think we're close to time. But I wanted to give each one of you a chance to say a 1 or 2 sentence takeaway from what you've presented. What should we be thinking about going forward? What's a key lesson that you want to give us? So I'll go in the same order of presentation. So Steve, quick answer.
Sure, there are a bunch of effective things that can be implemented in communities that are cost effective, that can improve health equity. Search them out and work to implement them, and you can make a difference. And they're not that complicated. Water to kids.
Thank you. Russ?
Leadership. I think so often we find that where great things have happened in promoting kids' health, there's a energized, inspirational leader that has taken hold of the situation, mobilized the resources, and made things happen. We just need more of those people.
Great point. Chris?
Great, and I'll pull it together and say, if you understand the context in a community and what the structural barriers are, then leaders can thrive and implement those cost-effective strategies that Steve talked about. So it's all of it. And I think, the 3 things we presented are all important in getting to where we need to go.
Yeah. Okay, well, thanks to the three of you for your informative presentations and for this discussion. And I will turn it back over to Dan, and he'll tell us, I think, about a break.
Yes, thank you for that terrific panel.